Okay, Herd, welcome to another news roundup. How you doing?
It's news roundup time. Doing great.
Yep. No, so it's March 2026, and we got a lot of activity. So today, I thought we'd hit on 6 stories. Is that okay?
That sounds good.
Okay, so the first one is out of Fierce Healthcare, early March 4th, and it's really talking about commentary by HCA Healthcare. In that, it's talking about the One Big Beautiful Bill Act and some of the potential decreases in inpatient days. And they're saying they're at an all-time high capacity for inpatient care, and they really don't see attrition hurting the overall growth of inpatient care. That's a little bit of a surprise, right? But
Yeah, I mean, the story we've been telling is, and I think it's true, but just the push from inpatient to outpatient.
yeah,
We've seen, this year we've got over 500 new procedures added to the ASC list that are able to perform in an ambulatory surgery center. The different projections. I was actually down in Houston last week and gave a talk all about utilization patterns
hmm
and everything pushing towards outpatient. This is different. So
yeah.
it's kind of a neat, not neat, but just interesting that things don't always move exactly how you want to. I still think the overall trend is towards outpatient, but this is certainly shows that there's lots of inpatient work out there.
Yeah. A lot of respect for HCA, though. I mean, they've got some great analysts, so I got a feeling they got a pretty good beat on this one. The second story is really, again, another fierce healthcare story. This is not news to us, though. It says patients with multiple chronic diseases are a looming threat to health systems financial viability. That's not a threat at all, right? Or that's not a surprise to you and me. Chronic illness is absolutely going to be a financial burden to health systems, right? I mean, it's going to
Yeah,
be challenging.
I mean, we were back to my Houston talk, talking a lot about just the cost of healthcare, the percentage of our GDP that healthcare is, and how we see it on an upward trend, and how it's after being flat for a number of years, excluding COVID, it's kind of back on an upward trajectory. And I think a
Yep.
big piece of what's driving that upward trajectory is we call it the younger, sicker generation, and we're seeing younger people with more chronic diseases and more chronic issues going on. So this doesn't surprise me at all.
Yeah, there's an interesting data point in this. It says 11% of the US population with multiple chronic conditions accounted for 52% of inpatient admissions. That's crazy, right?
Yeah,
So,
that's you see that stat in other places where you have a very small number of high utilizers that drive a big piece of the cost.
yeah, I
And I
think
think
we're normally used to the end of life care, right? It's the end of life is the huge bolus of the most care. This is saying there's an 11% cohort of people in the US that are accounting for this 52% of all inpatient care. So, yeah.
yeah, it's certainly more than I would think, and I'm sure if we dug into the study, we could maybe quibble with it, but I do
Yeah.
think addressing chronic disease and addressing some of these issues. I think we've seen that recently with some of the food pyramid. I think you have a new food
Right.
pyramid that's upside down and kind of trying to change diet, trying to change things that will hopefully affect this in the long term.
Yeah. Yeah. I agree. Okay, third story is about some ER docs and really hospital doc alignment and misalignment here. And this is talking about in Oregon, these ER docs are being ousted after 35 years, but they're not going quietly. That's a story in MedPage today. I've seen this multiple times where the overall medical staff at this facility basically gave a vote of no confidence to the hospital leadership after making this decision to get a national operator for ER docs to come in and replace later this year the ER docs that they've had for 35 years. That's pretty significant, right?
That's very significant. I mean, I think hospital physician relationship. I mean, that's a key, item. You want that to be good. You want that to be strong. I mean, that drives anything, from referral patterns to just patient satisfaction to quality of care. So yeah, that's an interesting story, and would love to know more details underneath it because I
Yeah,
wouldn't
but I
think
but
a
I
hospital would make that decision lightly, but I know the physician group wouldn't make that lightly either. So that's really interesting.
well, yeah, I I see where they're going though, right? I mean, one of the biggest drivers of spiraling costs for hospitals is on subsidies for physicians. So you think about the big ones: anesthesia, radiology, ER, pathology, and hospitalists. Those are the big five. And so the tension is always, I'm contracting out for this service, and in return, you're going to guarantee that I'm made whole by this subsidy. Well, this Oregon outfit, I can only imagine those conversations are probably saying, well, I can't afford the subsidy to pay you people. Therefore, I'm going to go out to market. Well, obviously, that was a terribly unpopular decision.
So there's a show out there called The Pit. It's a new show, came out a couple of years ago, and I just watched season 1. I'm about a year behind. I'm always behind on that kind of stuff.
I am
but
too.
One of the things that's interesting about it is it really highlights this tension between hospital administration and the main ER doctor, and so they're always butting heads about things. So just a probably an over dramatic, but maybe this is maybe they're onto something there and just kind of capturing that tension between the two.
Oh no, they're at that. My wife loves that show. I need to watch it because it's got what's his face, Noah Wiley. That guy's awesome from the original ER.
Yep.
Okay, next story is about this rural health transformation. You and I have been dealing with this because a lot of the states are asking for help from people like us. And so this one is most states investing in value-based care with rural health transformation program. Again, another article out of Fierce Healthcare. This is talking about, and so you know what that is? That's out of the One Big Beautiful Bill Act. There's a $50 billion rural health transformation initiative. On average, every state's going to get around $200 million over the next 5 years. And the focus is how can we improve access to rural healthcare, and a lot of this. So this article in Fierce was talking about how most states are going to really be diving in on value-based care with a real focus on access to care with digital health and telehealth in particular. So that's something that we're going to be watching very, very closely on how states want to use this these funds out of the Rural Health Transformation Program.
Yeah, I mean, we talk quite a bit about rural health and the challenges that rural health faces. We talk quite a bit about just the emergence of, I call it the haves and the have-nots in healthcare, and there's some very well-run, very well managed systems that are very large, and they're doing well, and they're figuring it out. But rural healthcare is one of those areas where they're really struggling, and I think with this, these funds that are available, it'll be interesting to see how they're deployed and see if we can make a real impact. On leveling up, rural health, because I think that's a very important item in this country.
Well, this article is very, very scary about the hundreds of hospitals that are apt to close because they're just in a financially terrible spot. I think the last story I've got here is around Medicare Advantage, what's going on with Medicare Advantage, and in particular CMS and the price raise. With the CMI and all the expense escalation with tariffs or whatever it is, what we see here is that the insurance, actually I have two stories. I have one more after this one. Insurers issued dire warning about Medicare Advantage payroll. And the deal is, so far, CMS is saying the proposed raising rates by just 0.09% for 27. That's tricky, Herd, because of just all these rising costs, right? So no wonder people are gritching about that.
Yeah, I mean, this came out, and when this came out, and this is the money that the Medicare program pays to Medicare Advantage plans to then manage that care, and so basically it's the money they get, and then it's the managed care or the Medicare Advantage program. And so what was interesting is when the story came out, a lot of the healthcare stocks and a lot of the provider or the payers that are a part of this, that they went down substantially because this really affects the money they have. I think from a hospital perspective, and we've talked about this internally, is you have over half of Medicare recipients are enrolled in the Medicare Advantage plan, and so this is going to affect the financial incentives of those plans, and they could start managing care more tightly. They could raise premiums. I mean, there's certain things that they can do to try to offset this, and so it'll be a real tension point between the beneficiaries that are on Medicare Advantage plans and also the providers that serve these beneficiaries. I think we're going to see some just more tension and more maybe headbutting in that area because of this.
Yeah. Okay, so then getting on to my last story. This one is about 340B. There's a lot of hand wringing by hospitals and health systems who have 340B access. And this is two of the big drug makers, Novo Nordisk and Eli Lilly, are going to they're not threatening, they're actually going to tighten 340B oversight. And this is an article in Modern Healthcare in early March 5th. And it's just talking about how the accountability and the documentation is going to significantly tighten up on hospitals to really try to rein in some of the extremely high 340B costs that are being paid out by a lot of these pharmaceutical agencies. So 340B is a huge revenue driver for hospitals and health systems, right, Herd? And this is something that people are going to be quite anxious about.
Yeah, I mean, I feel like 340B has been in the news some way or another for the last almost 10 years, it seems like.
Right.
And this is a program where hospitals or providers can access discounts, pretty deep discounts on drugs. We see this program helping to keep cancer programs alive and financially solvent because
Yeah.
the reimbursement is maybe not enough if they had to pay full price for these drugs. So it's a pretty vital program. But it has grown beyond, I think, what original intentions were. And so
Right.
the cost of this program is much more than maybe it was originally intended. So we're seeing lots of changes. I know one of the changes that is out there that they're piloting is instead of receiving a discount on the front end, you actually have to pay full price for the drug, and then you get a discount or a rebate later on.
Oh, yeah.
And I think that's where some of this oversight's coming in, and so
Right.
it gives them more of the administrators of the program more of an opportunity to tighten down or maybe deny those rebates. And so that kind of changes the economic picture and changes some things. I agree that you probably need to tighten costs, probably need to oversight and have some oversight there. But for the programs that really depend on it, it's going to cause some operational headaches and some operational hurdles they're going to have to figure out how to overcome.
Well, I would think that it may lead to, you hate to say, but some ethical dilemmas too about rationalization, because if a hospital doesn't get 340B pricing for, one of these super, super high end drugs, then the question is, are they going to have to make the terrible choice of either providing this for them or being financially viable? So that's a terrible choice that they may be forced into, which you hate to see.
Yeah,
So,
it'll be interesting to see how all this
yeah.
shakes out.
For sure. Okay. Well, Herd, those are my 6 stories for this week. A lot going on, and we appreciate your time today and look forward to the next time together.
All right, we'll see you next time.